Hello and welcome to this weight loss surgery online seminar. My name is Mohammed Fatia, and I'm a bariatric surgeon with Atlantic Medical Group and at Overlook Hospital. Over the next 30 minutes or so, we are going to go through weight loss surgery. We will summarize procedures, workup, and life after surgery. A little bit about myself. I'm originally from New Jersey. I went to Tufts University Medical School in Boston. I then did a fellowship in minimally invasive surgery and weight loss surgery at Columbia Presbyterian in New York. I then moved back to the area, started the bariatric program here at Overlook Hospital in 2003. I was chief of bariatric surgery, and now I am director of minimally invasive surgery at Overlook. So we're going to go through a introduction, talk about treatment options, procedures, pathway to surgery, and what to expect after surgery. Weight loss surgery is not anything new. It's been performed regularly in the US for over 30 years. However, it has become more popular partly because famous people have had the surgery and we've seen their struggles with weight and their successes post-surgery. Also, medical advances have increased the safety and decreased the risk associated with weight loss surgery to the point where it is the most commonly performed, safest surgery in the US. Despite that, less than 1% of patients that suffer from obesity actually undergo surgery. So in other words, 99% of patients who suffer from obesity go through life with inadequate treatment for obesity and all of its associated health conditions. What is morbid obesity? It's important to remember that morbid obesity is a serious medical disease. It's not just a weight problem. It's a complicated metabolic problem that occurs when you hit approximately 100 pounds over your body weight. Another way that we look at this is by using a term called body mass index. Body mass index is a ratio between your weight and height. A body mass index of 30 or greater classifies as obesity. This is a typical scale that shows the ranges of BMI. 18 to 25 is healthy, overweight 25 to 30, obese over 30, severely obese 35 to 40, and morbidly obese over 40. This is a typical body mass index table. And across the top, you could see the weight. Across the left-hand column is height. And body mass index just uses height and weight. It does not use gender or age. And it's a way of us comparing apples to apples. So for instance, if you were 5'4" in height and you weigh 240 pounds, your body mass index is 41. Why is body mass index important? We know that as the body mass index increases, your risk of death increases. And that really speaks to the seriousness of obesity as a disease. You can see that as you hit a body mass index of 35, that you're 2 times more likely to die than that of a normal weight person. As you approach a body mass index of 40 or over 40, you're 4 times more likely to pass away from obesity and all of its related health conditions. Obesity affects people physically and psychologically. 70 million Americans are obese or severely obese. 1 in 5 children is obese. So this is certainly not a very common disease in the US. Obesity can reduce a person's lifespan by up to 15 years. We know it's the second leading cause of death after tobacco use. 6,000 Americans die each week due to obesity. Approximately 300,000 Americans die each year due to obesity. These are all of the health problems that go along with obesity: cardiac disease, heart failure, high blood pressure, diabetes, high cholesterol, arthritis, gallbladder disease, sleep apnea, infertility, urinary incontinence, several different types of cancers, and depression. And most patients that have obesity suffer from 1, 2, or more of these problems. they'll see their physician. Their physician will control these with medications or surgery if needed. However, we know that if you treat obesity as a root cause, these problems improve, if not totally go away. Your risk of developing different types of cancers goes away, and depression is improved. Then there's the personal impact of morbid obesity. These are quotes I've gotten from my patients over the years. I'm too embarrassed to go to the pool with my kids. I couldn't fit on any of the rides at Great Adventure. I can't tie my shoes. I can't sleep through a whole night because I stopped breathing. I'm in constant pain. I always avoid being in pictures. I don't like to fly because I need a seatbelt extension. Through all of these quotes and all the years that I've been doing bariatric surgery, you really get a sense of how this disease impacts people, not only physically or health-wise, but also personally. And the point of weight loss surgery is for you to achieve your goals in life. For all of these reasons, obesity has been declared an epidemic by the Surgeon General. However, it's still a relatively neglected public health problem. If we just look at a map of the US, starting in 1985, relatively low percent of the population suffering from obesity. But as we jump in 5-year intervals, you can see that the prevalence increases and America as a whole is getting more and more obese. When we look at 2020 numbers, you can see that the majority of the country has an obesity rate of over 30%. Now, obesity, we know, is a complicated disease. It does involve genetics, environment, and behavior. Genetics have not changed that much over the last 30 years, but environment and behavior have. We see an abundance of high-calorie foods. We see an increase in portion size and calories. We see also a decrease in physical activity. So just to give you a couple of examples, this is what a normal bagel looked like 20 years ago, about 3 inches in diameter, approximately 140 calories. Today, an average bagel is 6 inches in size, 350 calories. So 2 to 3 times the calories. Cheeseburger, 20 years ago, 330 calories. Today, average cheeseburger, 590 calories, twice the calories. French fries, 20 years ago, 210 calories. Today, average portion size, 610 calories. Again, 3 times the calories. Soda, 20 years ago, a 6.5 ounce bottle, 85 calories. Today, a 20 ounce bottle was 250 calories. Again, over 3 times the calories. Turkey sandwich 20 years ago, 320 calories on average. Today, a turkey sub, 820 calories. Again, almost 3 times the calories. Even coffee 20 years ago was a simple cup with some milk and sugar, 45 calories. Today, a mocha coffee with steamed milk and syrup, 350 calories. So on average, what we consider normal is 2 to 3 times more calories than even 20 to 30 years ago. Foods have also become more processed. As they become more processed, we notice that there's more calories per pound. So foods above this red line are foods that are not processed: vegetables, fruit, whole grains, beans. And you can see that the calorie count is less than 1,000 per pound, whereas below the red line are the processed foods, and the calories are greater than 1,000 calories per pound. So what this means is, as we eat more processed foods, we get in more calories per portion size. And I have a couple of examples of this. This is what 200 calories looks like of a muffin. And you can see it's approximately half a muffin. And you can imagine that you could eat half of this muffin, still feel hungry, and eat the other half. Whereas this is 200 calories of apples, probably 2 apples. It would be probably difficult to eat this whole plate of apples. You would certainly feel full before you're finished and less likely to eat something afterwards. Similarly, this is what 200 calories of a cheeseburger looks like. You can easily eat this and the other half. This is what 200 calories of carrots. Again, probably very difficult to finish this plate because you would feel full and you would not have any other food after that. This is 200 calories of a candy bar, only part of a candy bar. Again, just like I had said before, you would probably be able to finish this and finish the other half, whereas this is 200 calories of celery. Very difficult to finish this plate of celery. You would feel full and not be able to finish it. Then there are also sugary drinks. This is where a lot of people consume most of their calories. And you can see that a lot of these drinks, things like Monster Energy or Mountain Dew, we realize that they have high amounts of sugar. Mountain Dew has 19 teaspoons of sugar in one bottle, but also things that we think are healthy, like vitamin water or Gatorade, 8 teaspoons of sugar, even cranberry juice, 17 teaspoons of sugar. So again, a big source of calories that on a daily basis add to the increase in weight. So what are treatment options? There's obviously non-surgical, diet, exercise, behavioral modification, weight loss programs, appetite suppressants, and then there is surgery. So I'm sure everybody has tried a diet, and all the diets tell you that the results are not typical. Most will not result in long-term weight loss, and most people will regain their weight back. In fact, 99% of patients who suffer from morbid obesity fail these therapies. So it's not that you failed the diet has failed you. These diets are not built or made to treat patients who have morbid obesity. Again, because morbid obesity is a metabolic disease, not simply a disease that can be reversed by eating right and exercising, even though that is an important part of the process. That's where weight loss surgery comes in. So why surgery to treat morbid obesity? As I stated before, obesity is a complicated metabolic disorder. We know that surgery, not only does it limit the amount of food you eat, but it does have a metabolic effect. It has the ability to reset your metabolism and reset your weight set point, therefore helping you lose weight and to better maintain weight long term. Isn't weight loss surgery dangerous? I get asked this question often. Weight loss surgery is one of the safest commonly performed surgeries in the US. Just the risk of complication is less than 1%. The risk of death is less than 0.1%. When you compare that to the complications that are related to obesity or the risk of death related to obesity, this is a much, much better avenue to take. Do I qualify for weight loss surgery? We use the National Institute of Health guidelines for qualification for surgery. This was set in 1991. It states that if you have a BMI of 35 or greater with medical problems, you qualify for surgery. A body mass index of 40 or greater with or without medical problems qualifies for surgery. Also in 1992, the NIH concluded dietary therapy really has a high failure rate in terms of treating obesity. Despite that, it's been perpetuated through the years where every time you go to a doctor, they'll tell you to eat right and exercise, when we know that this has an extremely high failure rate in actually treating obesity as a disease. So what are the surgical treatments? There are two broad categories of surgical treatments. They are restrictive and restrictive malabsorptive. Restrictive means we make the stomach smaller. Restrictive malabsorptive means we make the stomach smaller, but we also alter the intestines so you absorb less calories. These are the two operations that I perform most commonly. They are the gastric sleeve and the Roux-en-Y gastric bypass. The gastric sleeve is by far the most commonly performed surgery in the US and in my practice. Essentially, what we will do is we will come in and we will staple the stomach to create a sleeve-like stomach, so a narrow tube-like stomach. This part of the stomach over here is removed. So this surgery is permanent. The stomach functions totally normally from top to down. Food comes in, normal digestion occurs and goes through the intestines. This part of the stomach, not only is it there just to hold extra food, which you don't want to do if you're trying to lose weight, but it also produces a lot of hormones that affect appetite. And by removing this part of the stomach, your appetite hormones actually go down. So you have less appetite and feel full quicker. The surgery is safer than the bypass in terms of complications, both long-term and short-term, and weight loss is a little bit less than a bypass, but very close. What are the benefits? It's minimally invasive. There's no foreign material. There's no malabsorption of nutrients or vitamins. There's no rerouting of the intestines. You eat 3 meals a day, no calorie liquids, exercise, and also it is important to remember the surgery does not treat reflux. However, patients' reflux oftentimes improve as they lose weight. This is surgery, and with every surgery, there are complications. Early complications include bleeding, infection, leakage from the staple line, pulmonary embolism, which is a blood clot to the lung, heart and lung complications, risk of death. Again, all of these are less than 1%. There are very minimal late complications associated with the sleeve. The next surgery that I do is called the Roux-en-Y gastric bypass. You can see that this surgery already looks more complicated. What we do is we basically divide the stomach, so that way you have a small pouch. We then divide the intestine. We reattach the intestine to the pouch, and then we attach the intestine to the intestine down here. So when you eat, you feel full here and here. This goes down, digestive juices come down here, and you get normal digestion. If you look at this picture, you can imagine that this also looks similar to the sleeve. However, the sleeve is made by a section of intestine as opposed to stomach. This at one time was the most frequently performed bariatric surgery in the US. And it also has slightly more weight loss than the sleeve. It is minimally invasive. There's no foreign material, no adjustments similar to the sleeve. It also has a slightly faster weight loss. It is what we used to call the gold standard of bariatric surgery. So every time a new bariatric surgery comes up, we always compare it to the gastric bypass. What are important details associated with the gastric bypass? You eat 3 to 6 small meals, no calorie liquids except for protein shakes when needed. Exercise is important. Vitamin supplements are important, secondary to the malabsorption component of the bypass. Just like the sleeve, or just like any other surgery, complications are possible. However, again, extremely low, less than 1%. They include bleeding, infection, leakage from the anastomosis, or the connection between the stomach and the intestine, blood clot to the lung, heart and lung complications, risk of death less than 0.1%. Unlike the sleeve, late complications are slightly more. They do include bowel obstructions, internal hernias, incisional hernias, complications of the anastomosis, such as strictures or ulcers. Again, very rare, most commonly managed by medications, sometimes need surgery. With all of these surgeries, whenever we do surgery, we always look for a hiatal hernia. A hiatal hernia is a small opening in the diaphragm that allows the stomach to herniate upwards into the chest. Obviously, if we left this here and we tried to do the sleeve or bypass down here, this would affect your long-term results in terms of weight loss and also perpetual heartburn. So whenever we see a hiatal hernia, we will bring the stomach down, tighten up the muscle of the diaphragm to make the picture look like this. Then we go ahead and do our surgery, whether it's a sleeve or gastric bypass. So I've been in practice now for almost 20 years. I've completed over 1,000 cases. Average weight loss at 1 year is 80 to 100 pounds. No leaks, no surgical deaths. I do all of my surgeries laparoscopically. We use either 5 to 6 very small incisions. This translates into a shorter hospital stay, better breathing after surgery, and also a decrease in complication rate. This graph shows projected weight loss after surgery, and you could see the weight loss is slightly less for the gastric sleeve and more for the gastric bypass. However, they are very close. On average, I would say this difference may be about 10 pounds. Again, remember, we usually do the sleeve more commonly because of the lack of long-term complications, whereas there is a possibility of long-term complications with the bypass. So what are keys for success? It's important to have realistic expectations regarding the surgery. The surgery is a tool. It does not take care of everything for you. You do need to change your diet. You need to eliminate high-calorie foods, eliminate calorie liquids, and eliminate snacking. You also have to be physically active. So it may be difficult to be physically active now at this increased weight, but as you lose weight, you want to walk more, climb more stairs, take every opportunity to park further away, and take that extra time to walk to your destination. So what are the benefits with weight loss surgery? They include up to 90% successful long-term weight loss, 80 to 100 pound average weight loss, up to 75% resolution of high blood pressure, up to 95% resolution of type 2 diabetes, resolution of reflux disease, resolution of sleep apnea, improvement of musculoskeletal pains, and improvement in self-esteem. This is a slide that looks at benefits after weight loss surgery. This study looked at 5,000 patients, half of which underwent surgery, the other half underwent maximal medical therapy. And we see that there's almost a 90% reduction in the risk of death, with a risk of death in the surgical arm of 0.68% versus 6% in the medical arm. Surgery patients were less likely to develop cancer, less likely to develop infectious diseases, less likely to develop endocrine diseases, and healthcare costs were reduced by 34.5%. So how do we get from here to surgery? In terms of preparing for bariatric surgery, first step is a consultation with me where we talk about your medical history, weight history, and decide on a surgery that will work best for you. You then undergo a preoperative workup. You have follow-up visits with me on a monthly basis. And then when the workup is complete, we get insurance approval and set a surgery date. It's really important that over this period of time, you don't gain any more weight. We want to avoid what's called the Last Supper syndrome. So over these next several months, you need to start practicing and cut fast foods, junk foods, soda, and sweets out of your diet. So these high-calorie foods that may be part of your everyday life are things that need to be pulled out. Practice new eating behaviors, eating 3 meals per day, practicing small portions, avoid snacking, no liquid calories, no fast foods, no snack foods or processed foods. Cook at home, pack your own meals. You want to take a multivitamin every day, quit smoking, and exercise. This is all of the preoperative workup we do: lab tests, ulcer screening, gallbladder ultrasound, nutrition counseling, psychological counseling, routine health screenings, sleep study. You'll see a cardiologist, a GI doctor, and you'll also get a medical clearance. We do a lot of this workup with the Metabolic Weight and Wellness Center at Summit at Overlook Hospital. This is the team that will help you navigate through a lot of the testing at the hospital. Once everything is done and we get the insurance approval, we will do surgery at Overlook Hospital, where we are a ASMBN Center of Excellence, a hospital in bariatric surgery. We provide dedicated bariatric surgery services, healthcare personnel, private rooms, and facilities. As far as the day of surgery, you come in on the day of surgery. We will do your sleeve or bypass. You spend the night in the hospital. The next day, you get an upper GI where we get an X-ray of the sleeve and sleeve or bypass. Once we know that looks good, you get started on clear liquids. The nurses will be getting you up and walking, including the evening of surgery and during the next day. Most patients will go home the next day, so means you spend one night in the hospital. What to expect after surgery? After surgery, you will be on a liquid to soft food diet for approximately 4 weeks as your sleeve or bypass heals. You want to crush all your pills for the first 4 weeks. When you go home, we want you walking daily, at least 20 minutes a day, and you can shower as needed. So a couple of things to avoid after surgery: no driving for at least 5 days, just to let yourself heal up. No heavy lifting over 25 pounds for 4 weeks. And obviously, you want to avoid excessive liquid and soft food calories. So things that are high in calories, such as soda, ice cream, are things that you must avoid. Since surgery is permanent, you'll follow up with me and your medical team regularly. You'll see me often the first year and then every 6 to 12 months after that. Follow-up is required. You'll need to see your primary care physician regularly to continue evaluating health, also to manage your medications after surgery. Also, the nutritionist is available at the Weight and Wellness Center as you journey after weight loss surgery. And they are available to help answer questions and with meal planning. So as you lose weight, you still need to eat right and exercise. Eating right and exercise is a big part of this in terms of you losing weight and maintaining that weight loss. You cannot smoke. Smoking causes ulcers of the stomach. And it is very important that you will need to take multivitamins. Because you're not eating as much food as you were eating before, the multivitamins help supplement your diet. So what are the next steps? Kathy will call you to schedule an appointment. Make sure you have all of the appropriate referrals before you visit. If you've participated in any medical weight loss programs, if you collect that documentation, we could certainly use that with the insurance company. It's not necessary, but helpful. Feel free to explore our website to review frequently asked questions and learn more about the surgery. Thank you for your interest in weight loss surgery and joining me on this online seminar. We look forward to seeing you in the office and helping you achieve your goals. Thank you.